Well, hi, all. This is your host, Mike Hinkson, and welcome to another episode of Unstoppable Mindset. And today we are meeting once again with Dr. Joe Sherman. And if you remember our last show, Dr. Sherman is a board certified pediatrician and master certified physician development coach. And I won't give any more away because it's more fun to talk to him about all of that. But we had such an interesting discussion. It just seemed like what we ought to do is to have a continued discussion because we didn't get to cover everything that he provided to us last time. And I know we've probably got lots more that we can add to the discussion. So, Joe, welcome to Unstoppable Mindset. We're glad you're here again.
Thanks so much for having me, Michael. It's good to be back.
Well, glad you're here and all that. Do you want to start by kind of maybe refreshing people about you a little bit, life and all that? Anything that you want to give us just to start the process?
Sure. I currently live in Seattle, Washington, with my wife. We have a few grown children that are in their early 20s, and I am a pediatrician and now am a physician professional development coach, and I facilitate retreats for health professionals, medical teams. And most of my focus is on trying to bring who we are to what we do, kind of being more authentically who we are in our workplace, trying to come to our work with a more balanced mindset and trying to work a little bit more collegially as medical teams in today's ever-changing healthcare environment. So now I have practiced for about 35 years in pediatrics and am now devoting all of my time to coaching and facilitation.
Gosh, there's so many things that would be interesting to discuss, and I do want to stay away from the whole idea of politics. But at the same time, what do you think about the whole way the medical profession? Of course, one of the things that comes to mind is just everything that happened during COVID. But what do you think about the way the medical profession and some of the things that the profession is trying to do is being treated by politicians? And a lot of times it seems like people don't take it seriously, or it just doesn't fit into their agenda. Does that make sense?
You mean as far as the pandemic was concerned?
Well, the pandemic, or, there were some discussions about end of life or life discussions, and some people poo-pooed having that kind of thing and saying that isn't something the doctor should be doing.
Oh, I think right now, I think that politics and healthcare are intricately entwined. Especially after the pandemic. And I think right now, the idea of the politics getting in the way of a kind of the doctor-patient relationship is challenging. It's challenging for healthcare workers. I think where we desperately need political courage is in trying to develop a healthcare system that works for everybody in the country. So I think that that's where the focus should be.
What do you think about, and I've had a number of people tell me single-payer healthcare system wouldn't be a good thing. It's too socialistic, and we'll leave that out of it. Just wouldn't be a good thing. It seems to me that it has been very successful in a number of places, but the kinds of arguments that people give are, well, but by having competition, we have been a lot better at producing new and innovative technologies that wouldn't be produced or wouldn't be provided if we had just a single pay kind of system. I don't know whether that makes sense or I'm expressing it the best way, but it just seems like there's an interesting debate there.
I think there is debate because I do think there is some truth in the statement that our healthcare system has enabled development of technology and research in ways perhaps that other countries have not. On the other hand, our health outcomes and our health access for people who live in this country is not very good, especially given the degree of wealth that our country has. So I used to joke, although it's not that funny, but one clinic where I worked that was a low income clinic, I used to joke that if one of our patients were to come out of their apartment to cross the street to come to the clinic, they may be turned away at the door because they don't have any insurance or they don't have the proper insurance or they can't pay. But if they happen to get run over by a car in the street on their way across the street, there would be no questions asked. The ambulance would come pick them up. They'd be taken to the emergency room, given the best treatment to try to save their lives, admitted to the ICU, and incur a huge medical bill with the greatest of technology. But they would not have been able to have gotten that primary care appointment to begin with.
Yeah.
So we are very kind of high tech, high intensity, high specialized in our approach to healthcare, whereas other countries focus much more on primary care.
I know in 2014 in January, my wife became ill, started out as bronchitis, and it kept getting worse. And she didn't want to go to the hospital, and she was always in a wheelchair. So she found that they didn't really know how to deal with, she was congenital or always paralyzed from basically T3 from the breast down. And so she didn't like to go, but finally we compelled her to go to the hospital. It was on a Saturday, and the next day the bronchitis morphed into double pneumonia and ARDS. And her lungs ended up being 90% occluded. So she had, to get air into her lungs, they had to use a ventilator, and she had a PEEPS level of 39 just to get air into her lungs. Yeah, you know what that means. And it was pretty amazing. People came from all over the hospital just to watch the gauges. Mm-hmm. But she had literally just about turned 65. And we were very blessed that we didn't get any bill because Medicare, I guess, absorbed the entire thing. And we didn't know whether we would get anything or not. And we didn't. And she did recover from that, although she felt that she had coded a couple times and then her brain wasn't quite as good as it had been. But she did well. And so we got incredible care from Kaiser Terralinda up in the San Rafael area, and it all went well. Of course, we had gotten the pneumonia shots, and I complained to our physician. Talk about joking. I complained to our primary care physician. Well, you say that these shots are supposed to keep it from happening, but we both had the shots, and she got double pneumonia anyway. And of course, the unfortunate thing was that the doctor had an answer. She said, "Yeah, but it would have been worse if you hadn't gotten the shot." Darn, she shot me down, but it was fun to joke.
Well, I'm sorry that happened to you. That's a unfortunate situation.
It was, but things do happen, and we did get over it. And out of that, we ended up moving down to Southern California to be closer to family. Mm-hmm. So it worked out okay, but we love and really support the medical system in any way that we can. We see, both of us did, and I still, and wherever she is, she must see the value of what's done. And it just is so frustrating anytime people say doctors are crazy people. They don't really look out for people's interest, and just so many different things. It It's unfortunate because, I can tell you from personal experiences, I just said what we saw.
Yeah, I think that what is happening in our healthcare system now is this epidemic of burnout amongst health
Yeah.
professionals, especially amongst physicians and nurses. But and a lot of that has to do with the amount of administrative tasks and the amount of pressure that's put on physicians and other healthcare providers in trying to see as many patients as they can in the shortest amount of time as possible. And this is because of our system of fee for service reimbursement for medical care. The way that health systems stay afloat is by trying to see as many patients as possible. And this, unfortunately, combined with the amount of administrative work that needs to be done for each of those visits, plus the amount of communication that comes in from patients, as well as referral sources and requests for prescription refills, all of that comes in constantly through the computer of any physician that's trying to work as an outpatient or inpatient doctor. And it just becomes overwhelming.
Yeah. How do we fix that?
Hmm.
That's a
Well,
good loaded general question, isn't it?
it is. It is a good question. And I think it's a multi-pronged approach. I do think that one thing that has happened is that the technology of healthcare and the business of healthcare has changed dramatically during the time that I've been a physician, a pediatrician. And the culture of healthcare, kind of the way we do things, really hasn't changed. So that means that the business and the technology has placed more demands on us. And at the same time, we're kind of doing things pretty much the same way we've always done them. Because of these extra demands that are placed on physicians and other health professionals, what's needed are experts that are in those areas of billing, administration, technology, IT, all of those things that now all feed into seeing patients in the office or in the hospital. So you need all of those professionals working together side by side, along with the physician. Allow the physician to do the work that she's been taught to do, which is actually deal with the patient and take care of the patient, and then let other people do the data entry, do the billing, take care of all of the messages and other things that are coming in around that provider.
Do you think that the same level of burnout exists in other countries that exists here?
It does. I do think that burnout exists everywhere in healthcare. Um, I do think that it is less in low income countries, which seems kind of strange, but
Hmm.
I've worked for many years in my life in low income countries in Africa as well as South America. And it's a different culture. It's a different culture of healthcare. There are different expectations of doctors, I think, in other countries. Um, Especially countries that are used to seeing a lot of disease and mortality, um, the pressure on saving lives and the pressure on having to be perfect and always get it right and knowing everything to do it each time that a patient comes in is not quite as intense as it is here. Um, so I do think that it is different in other places. However, I will say that I have spoken to physicians in definitely in the more developed, higher income parts of the world, that this epidemic of burnout is pretty universal.
Now, it seems to me that I've been seeing in recent years more what they're called physician assistants. Is that a growing population, or is it always been there and I just haven't noticed it? And does that help?
I do think that in our country here in the US, the future will see many more physician's assistants and nurse practitioners, what we call advanced practice clinicians or advanced practice practitioners, um, providers. We're going to see many more of them doing primary care, and a model that I think would probably work very well is a team-based model where the MD, who is uh, uh, kind of trained at a much higher level for many more years, leads a team of other providers
Mm.
made up of physician's assistants and nurse practitioners to do primary care, to take care of a group of patients. And perhaps that MD is there to consult, to be backup, and to care for the more complex patients while the nurse practitioners and PAs are giving the primary care, delivering the primary care.
Well, I know that the PAs that I have dealt with um, through the years, it seems to me have, and especially in the last 10 years, but have been very, very competent, very qualified. And I don't know that where I would say that they're less rushed, but I've had the opportunity to have some good conversations with them sometimes when the doctor just doesn't have the time. So that's one of the reasons that prompted the question. It just seems to me that the more of that we can do, and as you said, the more that takes off perhaps some of the load from the physician itself may over time help the burnout issue.
I do think so, but I also feel like there's tremendous pressure right now on those PAs and nurse practitioners because they're under a lot of pressure too to
And there aren't enough of them.
produce. And yes, so actually, right now there's a movement within the federal government to expand the number of positions in training programs for nurse practitioners and PAs. We have far too few, especially physician assistant schools. We don't have nearly as many as we need
Yeah.
in this country. And if you look at the numbers, I think it's more competitive to get into PA school than it is to medical school.
Really?
Yeah, that's I that's been my experience of what I've seen from people. Just the number of applicants compared to the number of accepted.
They wouldn't let you into a PA school, huh?
Exactly.
Yeah.
So I had to go to medical school.
Yeah, no, I know. Um, well, it's it is interesting. I know we read a few years ago that University of California at Riverside actually started a program specifically. I'm trying to remember whether it was for training doctors. It was something that was supposed to be an accelerated program. Um, oh, um, some of the hospitals sponsored it, and the agreement would be if you went to the school, you'd get the education, you wouldn't pay, and at the end, and you would go to work for those hospitals. Like I think Kaiser was one of the major sponsors of it, and again, it was all about trying to bring more people into the profession, which certainly is admirable by any standard.
Yes, I think there are now there are a few medical schools, and they're expanding the numbers that have free tuition. And some of those schools, such as NYU Medical School, has a generous donor who has given a tremendous amount of money as a donation. And as an endowment, it pays for all the education of the students that go there. And there are some other schools that have the same arrangement. Uh, I think I think if I were to be boss of the country, I would make all medical education free. In return, people would have to work in an underserved area for a certain number of years, maybe a few years. And then after that, there would be free to practice debt free in any specialty and anywhere they would like.
Well, we need to do something to deal with the issue because uh, more and more people are going to urgent cares and other places with different issues. I have someone who helps me a little bit. She's our housekeeper, and she also comes over once a week for dinner. And she has some sort of allergy. Her face and her neck swelled up yesterday and had all sorts of red spots and everything. It's the second time she took not Benadryl, but something else that made it go away the first time, but it was back. And several of us insisted that she go to urgent care, and she went. And while she was there, she heard somebody say that they had been waiting 4 hours. So she left, which doesn't help at all. So I don't know actually whether she went back, because I talked with her later and said, go back. So I don't know whether she did, but the waiting time is oftentimes very long, which is unfortunate. And I don't know whether more people are getting sick, or they think they're getting sick, or they're just taking ailments that are less to urgent care, but there are definitely long waiting times.
Yes, people do not have a medical home. Many people don't have a medical home, a true medical home. That early in my practice, I'm a pediatrician. As a general pediatrician, if there was a child that was in our practice and at nighttime or over weekend, somebody would be on call. If that parent was concerned about a child in any way, they call the emergency line for the practice, the on-call line, and that operator would page whoever the doctor was on call. And I would, as the doctor covering, call that parent and talk directly at home, give advice over the phone, say what to do, make a decision of whether that child needed to go to the emergency room or not. Or in the vast majority of cases, could give advice over the phone about what to do and then follow up when the office was open the next day or on the next week.
Yeah.
But nowadays, people aren't connected to offices like that.
Yeah.
We have call centers, nurse advice lines of people that don't have access to medical records or have very strict protocols about what type of advice to give. And the bottom line and the safest thing is go to the emergency room or go to urgent care. So that's unfortunately why some of the highest burnout rates are in emergency room doctors, and some of the biggest problems with understaffing are in emergency rooms right now.
And I can understand that. It makes perfect sense to hear that. And it's unfortunate, but true. So, yeah, you're right. So many people don't really have a home. We've been blessed. Karen, my now late wife, of course, was always a patient of Kaiser and was a strong advocate for the way they did most all of what they did. And so I eventually, when we got married and we were in a Kaiser area, then I did the same thing. And mostly I think it worked out well. I think Kaiser is a little bit more conservative than some when it comes to perhaps some of the newer procedures or newer sorts of things, like we see ads on TV now for the Inspire way of dealing with sleep apnea as opposed to CPAP machines. And I don't know whether Kaiser has finally embraced that, but they didn't for the longest time. At least our doctor said that it wasn't really great to have to undergo surgery to deal with it, and the CPAP machines work fine. But I think overall, to use your words, definitely if you're in that kind of an environment, it is a little bit more of a home, and you have definite places to go, which I think is valuable. And I think that more people really ought to try to figure out a way to find a home if they can.
Yeah, I do think that it is Again, the amount, just society has advanced so rapidly and so much in how communication is instantaneous these days through texting and through internet and through uh, instant messaging, all these different ways that everything is sped up. So um, people are looking for answers right away,
Yeah.
and it's that's often puts too much pressure on the people that are trying to manage all of the patients that and all of their inquiries that they have. So I think we need to make some serious changes in the way that we staff hospitals, the way we staff clinics, and look and see what are the specific duties that need to be done, the specific activities and responsibilities in attending to a patient, and specifically target personnel that are skilled in that activity instead of having a physician who is not the greatest typist or is not the greatest at trying to figure out a code of billing for insurance or how to look at 100 messages that came in while she was attending to 25 patients in a clinic. It's just too much. It's overwhelming. And I mean, I now uh, facilitate a group. It's a support group for physicians through Physicians Anonymous,
Mm.
where physicians are suffering from anxiety, depression, addiction, suicide ideation, and it's really at scary levels right now. And I do think that the healthcare systems are starting to be aware of it. I think patients need to be aware of it. And the reason why, when you call, you're on hold forever, or you never do get to speak to a real person, or it takes months to get in to see a doctor, it's because nobody's home.
Yeah.
Everybody is, many people have quit.
Yeah. There's such a shortage. I know at least we see ads oftentimes for nurses and encouraging people to go into the field because there's such a shortage of nurses, just like there's a shortage of teachers. But we don't do as much with the conversation of there's an incredible shortage of physicians. I think it's probably done in some ways, but not as publicly as like nurses and some other types of positions.
Yes, I think right now, the I always feel like, I mean, this has been always true that on hospital floors, because the profit margin for hospitals is very narrow.
Mm-hmm.
There are only certain services that hospitals truly make a profit on. So uh, usually the staffing levels are kept to the very bare minimum. And now that just puts too much pressure on those that are remaining. And so now we're seeing many more hospitals have nurses that go out on strike
Yeah.
or decide to slow down or do other measures to try to get the attention of how dangerous it is to have understaffing in the hospital.
Have we learned anything because of all the stuff that happened with COVID? Now that we're in this somewhat post-COVID world, have we learned a lot, or anything, or is anything changing? And is there really ever going to be a true post-COVID world? For that matter, that's a fair question.
That is a fair question. And I do think recent changes in policy by the CDC of treating COVID as if it were influenza or RSV or other
Mm-hmm.
type of respiratory viruses is there are many physicians that disagree with that policy because this COVID-19 that we've been dealing with causes many more complications for those that have complex medical conditions. And this long COVID situation is something that
Oh,
we
yeah.
really don't have a grasp on at this point. But I believe one innovation, I would say, or expansion that has come about is the whole telehealth
Mm,
movement now, that there are many, many more video visits. I do think that's a good thing. I also believe that it can provide more flexibility for healthcare providers, which will help to decrease burnout if providers are able to perhaps do their telehealth visits from home, or be able to spend time doing telehealth visits as opposed to having to um, see patients in person. I think what happens now is we need to get better organized as far as which types of visits should be telehealth and which types should be seen in person, so that one provider is not going back and forth from, computer screen to seeing somebody in person back, and so that gets too disorganized,
yeah.
I think, at times. Um, Other things, I think we learned a lot about infectious disease. I think that the general public learned a lot more about infections and infection control. I think that's all good. I think one thing that we um, did not learn, unfortunately, is how desperately we um, desperately we need to do something to try to stem the tide of burnout,
Hmm.
because it just accelerated during COVID, and then has continued to accelerate because of the economic crunch that healthcare systems find themselves in now.
Well, and what is to me a little bit scary is all it takes is one COVID mutation that we don't expect or encounter, and we're almost in back where we were, at least for a
Mm-hmm.
while. And I hope the day will come when, rather than using the mRNA type vaccine that we use now, that we truly will have a vaccine like an influenza vaccine that can really kill the virus, and that we can then take, even if it's yearly, but that will truly build up the immune system in the same sort of way. Although I have no problem with the current vaccine. In fact, I'm going in for my next vaccination a week from tomorrow. And um, what cracks me up is I've been there a number of times, and some people talk about the conspiracies of all they're doing is injecting you with all these little things that are going to track you wherever you go. And I'm sitting there going, fine, let them. Then if there's a problem, they're going to know about it and they'll come and get me, But what I really love to do is um, a nurse will come over, she'll give me the vaccination, and she pulls the needle away, and then I reach over with my one hand and slap my hand right over where she did the shot. And I said, wait a minute, one just got out, I had to get it.
Mm-hmm.
And she says, there aren't really any trackers. I said, no, I'm just messing with you. Um, but it will be nice when that kind of a vaccination comes, and I'm sure someday it will.
Well, I think the vaccines, these types of respiratory viruses do mutate quite a bit. There's all kinds of variants, and they change every year. So I think no matter what kind of vaccine we get, we're still with infections such as
Yeah.
influenza or COVID, we're still going to end up needing to get annual vaccines, most likely.
Yeah. And that is the issue, that even with influenza, we do get lots of variants. And I know a couple of years, as I understand it, they kind of predict what strains to immunize for based on like what Australia gets in our middle of the year and things like that. But sometimes it doesn't work. That is, they guessed wrong when it gets to us, or it's mutated again, and it's unfortunate, but it is what we have to deal with. So for me, as far as I'm concerned, anything that we can do is going to help. And I really have found the current vaccines that we do get for COVID, at least whether it will totally keep you from getting it or not, which I gather it won't necessarily, at least it will mitigate to a large degree what could happen if you didn't take the vaccination.
Yes, yes, that's correct. We are we're seeing much less deaths as a
Yeah.
result of COVID infection. However, in the peak of the wintertime, in the clients that I've been coaching who work in hospitals and in ICUs, they were seeing still a large number of patients that were there. It's just that we've now developed better treatment and management for it, and so then less people are dying of it. But it is, you know, we have again the amount of research, medical research and development that has developed these vaccines has prevented so much infection that what doctors are called on to do now and what they're called on to treat and manage has shifted much more into areas of behavioral health and lifestyle change than it is treating infections. That's dramatically different experience through my pediatric training than what type of training that a pediatrician these days gets.
And there again, that means that the physicians have to spend the time learning a lot of that they didn't learn before, which also takes a toll because they can't be in front of patients while they're learning or while they're studying.
Yes, yeah, it's what the medical students and residents now are being called on to manage in the hospital are very, very complex, specialized conditions and very serious conditions. Um, my experience as a resident was much more, the vast majority of people I took care of as a pediatric resident were normal, healthy children who happened to get sick, mostly with infection
Mm-hmm.
and sometimes very seriously sick, come in the hospital, receive treatment, and walk out as a normal, healthy child again. We don't see that as often as pediatric residents, just speaking from pediatrician's point of view. And I think that has an emotional toll on the resident physicians. I got a tremendous amount of reward from caring for patients with serious infections that received antibiotics and got completely better than patients who already have complex chronic conditions that just get
Yeah.
worse or a
Yeah.
complication. And they come in and the resident helps to manage them a little bit and then sends them on their way, but really doesn't feel like
You've
they've
cured them.
contributed in the
Yeah.
same way and that was they don't have that same type of reward, that rewarding feeling, I think.
Are we seeing more of that kind of patient significantly more than we used to?
In the hospital, absolutely.
Why is
Yeah.
that? Is it
Well,
that there
because,
really are more, or what?
well, we've taken care of most of the serious bacterial infections that used to be treated in the hospital with antibiotics. We've taken care of them with vaccines. And then we've also advanced the quality and and variety of conditions that we can treat as an outpatient now, so that people that used to come into the hospital all the time for conditions, simple, basic things, are now treated as outpatients. And that's a
Mm,
good,
yeah.
because you don't want to be in the hospital any longer than you absolutely have to.
No. I had, well, my father, I don't remember how old I was. Um, it must have been um, in the, well, 1960s sometime. He had to have his gallbladder out. So it was a pretty significant operation at the time because he was in the hospital a couple of days and came home with a nice scar and all that. And then my brother later had the same thing. And then in 2015, suddenly I had this really on a Thursday night horrible stomach ache. And I figured there is something going on. I hadn't had my appendix out, but this wasn't right where my appendix was. But we went to the local hospital. We called Kaiser, and there isn't a Kaiser hospital up here, so they sent us to another place, and they took X-rays, and then we ended up going down. They took me by ambulance on down to Kaiser, and it was a gallbladder issue. So I guess all the men in my family had it. But what happened was that when they did the surgery, and by the time we got down to Kaiser, there was a gallstone and it passed. So I didn't want to do the surgery immediately, only because I had on the following Sunday an engagement. So we did it like a week later. The doctor thought I was crazy waiting. And then later he said, well, you were right. But anyway, when I had the operation, there were 3 little Band-Aids, and it was almost, I guess you'd call it outpatient, because I went home 2 hours later.
Wow. Yes.
I was blessed.
Yeah.
So it was almost like, and I've had colonoscopies before. I didn't spend any more time doing the gallbladder operation than I did really with all that I spent in the hospital doing a colonoscopy. It was pretty good.
Right. I do think that there's been, again, major advances in endoscopic surgeries and robotic surgeries and minimally invasive procedures to be able to treat patients. I mean, again, I have to say that our ability now to treat stroke and heart attacks, myocardial infarctions,
Mm-hmm.
our ability to treat those acutely, do something to try to improve the outcome, has improved dramatically just recently, I would say, especially stroke management. So what we have is amazing, dramatic changes in reducing the morbidity and mortality from stroke now. And I think that it's remarkable. Even as a physician, I didn't even realize until a recent trip I took to Bolivia with a group of neurosurgeons, how stroke is treated now. And it's phenomenal. Before you have a stroke and it's just kind of like, well, you hope for the best, you support, hope that some blood flow returns to that part of the brain. Now, if you have a stroke and people are taught to recognize it and immediately get to the hospital, they can give a medication to melt the clot or actually go in there with the catheter and extract the clot out of the vessel and restore you back to full function. It's remarkable.
And have a glass of red wine while you're at it. Or do we still say the TPA helps some of those things a little bit?
You know, it's interesting. It's as far as I think, I've never seen so many articles written about the consumption of alcohol, coffee, going back and forth and back and forth. What's helpful, what's not. Everything in moderation, I would say, at this point.
Yeah, I would not be a good poster child for the alcohol industry. I have tea every morning with breakfast. And the reason I do is that I decided that would be my hot drink of choice. I've never been a coffee drinker. The caffeine doesn't do anything for me. So it's more the tea and then a little milk in it. It is a hot drink. Ever since being in the World Trade Center, I do tend to clear my throat and cough more. So the tea helps that. And that's the reason that I drink tea. But I remember seeing old commercials about red wine can help you. So if I have a choice in wine, I'll oftentimes get red just because I've heard those commercials, and I don't know how true it is anymore. But hey, it's as good a reason as any to have a glass of wine every other week, and that's
Sounds
about what it
good.
usually is.
Yeah, sounds like a good plan.
Yeah, it works. Well, it's now kept me around for a while, and we'll keep doing it. It works.
Hmm.
So, what is it that healthcare workers and physicians do to kind of restore their love for what they do and work toward burnout? What can individuals do?
I think we're at a point now where in approaching the issue of burnout and approaching the issue of overwhelm with the amount of work that physicians are called on to do these days is a combination of personal changes to mindset and approach
Mm,
to our
mm.
work, as well as structural and organizational changes to facilitate our work. And I think that the organizational structural changes, again, have to do with trying to improve specific staffing to match the activities and responsibilities uh, that are called on in the medical setting, and being able to do more in the formation of medical teams and in teamwork and in people having a common mission, working together, appreciating what each other does, and hospital administrations and those folks that run the business of the hospital truly value and enlist the engagement of frontline workers in policy and procedures.
What?
So those are kind of structural changes. On the
Right.
personal side,
Yeah, that's what I was
a
going to
lot
ask.
of it has to do with being more realistic. And I'm speaking to myself too. We can't do everything for everyone all the time. We are human. We often have been taught that we are superhuman, but we're not. And if we try to do too much and try to do it perfectly, then our bodies will rebel and we'll get sick.
Hmm.
So I think we need to set boundaries for ourselves. We need to be able to say, these are the hours that I'm working. I can't work any more than that. We need to say that you can't reach me three different ways, 24 hours a day, all the time, and have me respond to all of those inquiries. We have to set limits, and we have to really look at what it is that we love about medicine, what it is we love to do within medicine, and really try the best we can. I think with the help of coaches and other types of mentors and folks that can help us to create the types of jobs and the types of positions that help us maximize that experience of fulfillment, that experience um, of feeling like we truly are contributing to the health and well-being of our patients.
Do you think overall that the kind of work you do and that others are doing to address the issue of burnout um, is really helping? Are we making more progress, or are we still losing more than we gain?
I think we're making progress on an individual basis on
Hmm.
people that do seek help. But we need also to change the mindset of ourselves as physicians to be willing to seek help. We need to seek help and admit that we need that type of support. But until we get organizational um, uh, commitment to trying to change the structures and the systems that we work under, then we will continue to have more physicians lost to burnout, depression, and suicide.
Are healthcare institutions recognizing more the whole issue of burnout, and are they really starting to do more about it?
Some, I think
Mm-hmm.
some are. I think organizations are recognizing it. Associations of physicians are recognizing it. Um, but when it comes to surviving as a health organization, healthcare institution, the bottom line is what runs a show.
Yeah.
And the way you make income is through billing. And the billing occurs as a result of a healthcare provider providing and billing for what they do. So if there's an economic crunch, the first thing to go is anything that doesn't generate income,
Yeah.
and supports for the well-being of staff does not generate direct income. What it does, though, is that it retains staff. It results in a happier staff, a more um, higher professional satisfaction, and in the long run is going to save you money.
Yeah, which is another way of making some more money.
Mm-hmm. Yeah, I mean the total cost, the average cost for replacing a physician who has decided to quit
Yeah.
is anywhere from about $600,000 to $2 million, depending on the specialty of the physician.
Yeah. And getting people to necessarily see that is, of course, a challenge, but it still is what needs to happen, because it would seem to me that those costs are just so high, and that has to account for something. That is still a fair chunk of money.
Yeah, it is. It's a great deal of money. Yeah. And, our system of healthcare, we were headed in the right direction. And I think eventually we have to get there to population-based health in looking at health outcomes and trying to look at overall health of our citizens and those who live here in our country, in trying to instead of having a fee-for-service model, have a model that looks at um, reimbursement for healthcare based on the total health of the patient. And that is contributed to by nurses, doctors, technicians, receptionists, um, community health workers, all those types of health professionals.
What can we do to get the wider society to become more aware of all of these issues, and maybe to advocate for change?
I think I think avenues like this, these
I was going to say,
podcasts,
this
I
podcast
think
is one. Yeah.
I also believe that look at your real life lived experience of trying to access healthcare today compared to how it was 20 years ago. And are you having more trouble? Is it more expensive? Are you having more challenges? This is direct result of a system that's not functioning well.
Did the whole process of what we now call Obamacare, did that help in the medical process in any way?
I think what happened with Obamacare was, and the bottom line answer is yes, it has
Yeah.
helped.
Mm-hmm.
And the way it has helped is that more people have access to health insurance. Less people are completely uninsured than ever before.
Mm-hmm.
So I think from that perspective, that's been helpful. But there were so many compromises
Oh,
made
yeah.
to insurance companies and to different lobbyists that were all looking out for their interests, that What ended up happening was a much more watered down version of what was initially proposed. But step in the right direction. And if we continue to work toward that, and we have some contribution of government sponsored health insurance, then we're going to be better off as a nation.
Yeah. Well, and anytime we can make a step forward, it does help, which is, of course, a good thing. So if there's one thing you want listeners to take away, or watchers, because we are on YouTube, if there's one thing you want people to take away from this, what would it be?
It would be pay attention to your own personal experience with healthcare. Pay attention to your own health and observe what's going on in the clinics, in the offices, and in the hospitals where you receive your medical care. If somebody is treating you well with respect and compassion, point it out, make it known, thank them.
Yeah.
Make it known that you know that they're under tremendous stress and pressure, and that anytime that they can be kind, then that means that they are very dedicated to treating patients. And if you're finding that where you're going to receive your health care seems to be understaffed, then say something about it. If you have a healthcare provider who is a bit snappy, is not patient with you, doesn't seem to be listening to you, it's not because they don't want to.
Yeah.
They desperately want to. It's just that the conditions are such that they're not able to.
And it would probably be good to at least engage them in a little dialogue and say, hey, I'm not trying to yank your chain here, and kind of try to help warm them up. I've been a firm believer that in a lot of places where I go, like in the airline world, the TSA people and so on, I love to do my best to make them laugh. So like when I go up to the kiosk and the TSA agent says, I need to see your ID, especially when I'm wearing a mask, I'll say, well, what do you want to see it for? You can't tell who it is behind this mask, right? And I've had a couple people who didn't expect anything like that, but they usually laugh at it. And then the other one I love to use is they ask for my ID, and I say, well, what's wrong with yours? Did you lose yours? Yeah. And I just love to try to make them laugh where I can, because I know it's a thankless job. And I know that what doctors and medical people deal with is a pretty thankless job too. So it's fun to try to make them laugh whenever I can and get them to smile.
Great. Yep. We all could use a little bit more humor.
Yeah, there's always that. So if people want to learn more about you and reach out and learn about your work and so on, how do they do that? Where do they find you online, or any of those things?
Sure. I have a website that you can go to. It's joeshermanmd.com. And you can reach me by email at joeshermanmd.com. I'm also on LinkedIn. So you can find me there too.
Cool. Well, once again, I want to thank you for being here. This has been a lot of fun and very enjoyable in a lot of ways, but certainly educational, and I've learned a lot. And we got through all the questions this time that we didn't get through last time, which is always a good thing. So see, it was worth doing it twice.
Great. Thank you so much for having me back.
Well, it was fun. And of course, for you listening out there, reach out to Joe. And I want to hear from you. I want to hear what you think of today. So please email me, michaelhi@accessibe.com, or go to our podcast page, www.michaelhingson.com/podcast. And Michael Hingson is michaelhingson.com/podcast. Would really appreciate a 5-star review from you wherever you're listening to us. We like those reviews if you can. If you know anyone that you think ought to be a good guest on Unstoppable Mindset, and Joe, you as well, we'd love to hear from you or provide us introductions. Always looking for more folks to meet and to chat with, and love the incredible diversity in subjects that we get to talk about. So that makes it a lot of fun. But I do want to just once more, Joe, thank you for being here. This has been enjoyable, and I really appreciate it.
Thanks so much, Michael. I enjoyed the conversation.